All right. So the dermatome, guys, just remind me when we start. Like, Miss Sue, you got your recorder on? Sorry about that. All right. So the dermatomes, these are areas of the skin. And again, they're innervated by spinal nerves. We talked about spinal nerves in chapter 14. There's 31 of them, and they correlate with different parts of the body. Okay. So the somatosensory cortex is what's going to process the signal. It's mapped out and it corresponds to a source of pain stimuli. Okay. Now, a minute ago, I was talking about your nociceptors, about how they're stimulated, okay, by different things. Thermal means, which are extreme temperatures, hot or cold, chemicals within the body, like acids or other chemicals that are produced by the body, like bradykinin, prostaglandin, and histamine, or physical pressure when something's pushing down on something like fluid or a tumor. Okay. And then I talked about the pain fibers. And I said the afferent fibers, these are your sensory fibers. So the brain senses something is wrong because these afferent fibers are sending a signal to the brain. Okay. The myelinated delta fibers, I call them the myelinated delta acute afferent fibers because they're sending that acute signal, acute because it's going very fast, okay? That acute pain, that sudden or sharp localized pain, and it's sending it across this myelinated A delta fiber. It's fast because it's myelinated or it has insulation around it, the myelin sheath. So it's sending that afferent, that sensory fiber, across that myelinated A or acute delta fiber, and you feel that sharp pain. So you stub your toe and you feel that sharp pain. And then I said a second after that, or a few minutes after that, really, that sharp pain will start to go away. And all of a sudden, you'll feel like this dull, achy pain. Now, that is your unmyelinated fibers or your chronic fibers. Okay. They're still using that sensory fiber, that afferent fiber, but now they're transmitting slowly because they're unmyelinated. No insulation. So the signal's moving much slower. And that's creating that lingering pain that you're now feeling, that chronic pain that might feel diffuse, like it's scattered all throughout the toe. That's what diffuse means. It's dull, it's burning, or it's aching. Okay. So now we're going to the pain pathways and we're talking about the dermatomes. All right. Again, if you look at chapter 14, it talks about your spinal nerves. You have 31 of them. They're associated with different areas in the body. And if we'll look at a dermatome map, it'll show you where each one of these are associated. I even mentioned this when I was talking about the spinal nerves because I was saying that there's a one called a phrenic nerve and it will stimulate your respiratory muscles. We'll learn about that in chapter 13 next week, how it stimulates your diaphragm and your respiratory muscles so you can breathe. But these dermatomes are mapped out to different areas of your body. So whenever you have pain or you're in discomfort, your somatosensory cortex recognizes that because the dermatomes are mapped out to certain areas, the body can try to relieve by taking some action. Okay. So the body is responding to the pain that it just sensed coming in on that afferent fiber. And now it's going to produce a response. Okay. So remember, I said if you grab something hot, the first thing's going to happen is that afferent signal is going to go to your brain, and your brain's going to sense that you grab something hot, and then it's going to send this reflex response or this efferent response. Now, that's going to be an action. Okay. It's exiting the brain. Efferent means exit. So this reflex response is exiting the brain and going out to wherever that pain is. And it's going to cause a muscle contraction or a reflex, okay, to move your hand or your body away from that hot item. All right, spinal thalamic bundle in the spinal cord. So in that spinal cord, you have neurons that connect to the ascending tracts in the brain. There are two types of tracts in the spinal thalamic bundle. These tracks here, the spinal thalamic bundle, is what is conducting those pain signals. Okay. So you need to know that. So it's called spinal thalamic bundle, and that is what is conducting those pain signals. Now, how do I know the difference between which one is sending the fast signal for the acute pain or the slow signal for the chronic pain? Okay. And this is how I remember. Okay. Neospinal. Okay. I call that my neosporin track because when I have an acute cut, a cut that just happened and I got acute pain, I'll put neosporin on it, right? To help it real fast. So neospinal thalamic or my neosporin spinal tract is going to send those fast impulses or that acute pain signal. Now, paleo is caveman, okay? The caveman ate a paleo diet, okay? So that's going to be that slower, older pain, that chronic pain. So paleo-spinal thalamic is going to be that slow impulse, that chronic, dull pain. Because our cavemen, they were slow and laid back and they ate that paleo diet. So that's how I remember those two. Okay, now the spinal thalamic tract connects with the reticular formation, which is where your what is. How about that RAS? RAS. Your reticular activating system, right? The RAS does what?
Arouse.
It decides like
Arouse
what
your
information
ass.
is important to take in and what's important and like which ones to ignore.
So it's going to arouse you, the RAS, okay? And it's going to let you know that this pain is occurring. So good. All right, the somatic sensory area is going to be in your cerebral cortex. And that's where the pathways are that are carrying that information for touch, pressure, pain, temperature. Okay. And it's bringing it in from the skin, the muscles, the tendons, the joints into the brain. It does that on those afferent signals. Okay. Because afferent is sensory or incoming. If it's going to move your hand or cause a reaction, then it's going to be efferent. It's going to exit the brain and go to that area and make some action happen. Okay. So those tracks are connecting with that reticular formation in the brain, your hypothalamus, which you already know is your relay center, your thalamus, and other structures. Okay. And those go into that somatic area of the cerebral cortex. Okay. And that's where the pain is going to be received. All right. And then connections from those tracks will send information out to parts of the brain, and the brain will decide how it wants to respond. Again, the arousal state of that reticular activating system in the pons and the medulla will influence the brain's awareness of that incoming pain stimuli. All right. So once the tissue is damaged, okay, the nociceptors will be activated. So the injury occurs, it induces pain. Those afferent receptors are going to send that signal up to the spinal cord. The signals can come from the mechanical, the chemical, the thermal, nociceptors. Those afferent receptors are transmitting those signals to the neurons in the spinal cord, and they're going to relay it, okay, through those spinal thalamic tract up to your reticular activating system and then on to the brain. So as that happens, chemicals and hormones are going to trigger another response. And that can trigger analgesic properties to try to help your body limit the sensation of the pain. All right. You do have to know this gate control theory. Okay. It's been modified over years. It is kind of a complex theory and they don't quite understand it, but they try to use it to explain the to explain the pain pathways. All right. So the gate control theory says that there are neurological gateways in your brain and they decide which pain signals will come through and which don't. So really, this is what they base the TENS unit and ice packs and heat packs off of. Okay. So according to the theory, there are gates built into the normal pathway in the body that can modify the entry of the pain stimuli into the spinal cord and the brain. The gates are built into the normal pathway and they modify the entry of the pain stimuli in the spinal cord and the brain. The gates can be closed to reduce or modify that pain signal or that pain impulse. The gate closure can be in response to other sensory stimuli that competes on the nerve pathways. So that would be where your TENS or your heat or your cold comes in. So when you have the ice pack on that swollen ankle, it sends that signal of that cold to the brain and it overrides the pain signal to block the pain message. So the gate closure occurs in response to this other sensory stimuli. It competes with the nerve pathways and it can diminish the pain sensations by inhibiting the impulses from those high centers in the brain. For example, you apply ice to a painful site. This reduces the pain because you're more aware of the cold than the pain. A TENS unit is a similar situation. It increases the stimulation at the site, blocking the transmission of the pain. The brain can also inhibit or modify incoming pain stimuli to produce efferent or exit transmissions, outgoing transmissions through the reticular formation. Factors that can activate this built in control system include prior conditioning, the emotional state of the person that's affected, or distraction from other events. So, one of the things we also use for people when they're in pain is what?
Medication.
Not medication. Forget medication right now. Okay. You'll use distraction, right? Try to make them think about something else, put them in another place. All right. So this is just this slide. Just take a look at it when you have a second. Okay. And it's just explaining how the gate theory works. You just have to be aware of the theory. It's really associated with the ice and the heat. Again, we're sending another signal. Okay. Now, substance P, if that's released, the person's going to feel pain. So we try to block the substance P. So if you look over here on the right, a painful stimulus occurs. Okay. It's on that incoming or that sensory afferent fiber, and it's going up through the body here. Okay. The body is going to release interneurons, like your endorphins or your enkephalins, and those will go to the opiate receptors and they'll block the substance P from being released. The gate closes and it blocks that pain signal from going up to the brain. Okay. So the interneurons are activated from either the afferent pulse when you touch it, or it could also be activated when the body sends that exit signal back out. Okay. It can trigger the release of them endorphins or those enkephalins. These are like uh, built in or what we call endogenous morphine. So it will be released either from the afferent signal or the efferent signal to block the release of that substance P. If we block the substance P, they don't feel the pain. So your drugs will be based on a similar theory. or sometimes the drugs will also decrease our reticular activating system. Okay, so we're not as aware. Again, look at the painful stimulus. It's traveling along your A delta, which is what? What kind of pain goes there? On the A delta. What kind of pain is it?
Acute.
Acute. Okay.
Yeah,
And
acute.
C pain is going to be what? C pain fibers is going to be what?
Chronic.
Chronic. Okay.
Chronic and slow.
Chronic. So you have this painful stimuli, it's released, that activates the substance P to be released. Okay. That substance P sends pain up to the brain. As the pain signal's going up, your reticular activating system is alerted, and then the pain goes up to that cerebral cortex, okay, where it's sensed. Okay, so we can block the pain impulses to the brain when the body releases those encaphalons and that endogenous morphine. Okay, this is what it's talking about. The body releases opiate-like chemicals from the inner neurons. You have to know that part. Where is it released? From those inner neurons. And they act as a pain blocking or pain relieving medication. So they're called endorphins or endogenous morphine. And this includes enkephalins, dynorphins, betotropins, and they're blocking substance P to prevent pain. Got to know that. All right. So we look at the location of the pain. It's real, but it is subjective. Descriptions of it. You should let the client give you that. Okay. Because if you start naming things to them, they're going to say what you name. When does that happen? Okay. Is it in the morning? Is it before you get up? After you get up? And then evidence. Okay. Pallor, sweating. So usually those kind of things we're going to see with someone that has acute pain. Not a lot of times when they have chronic pain, the body sort of becomes used to it. All right, physical evidence is pallor, sweating, high blood pressure, tachycardia. They can also have nausea, vomiting with acute pain, fainting, and dizziness, anxiety or fear, especially people that have like cardiac pain, chest pain. Clenched fish, rigid. This could be pain, okay? So, in association with this, yes. But not everybody that has a clenched fist is in pain. Okay. Some of them about to punch you in the jaw. They're angry. So, other things that would go along with that would be guarding or knowing that they have some other issue going on. Or they're restless. They can't sit still. Now, you have to know this, okay? Young kids and infants, okay? So, infants, I say they have the Donald Trump look, and I'll explain that in a minute. But physiologically, it's not going to be clenched fists. So don't fall for it. It's going to be an increased heart rate, tachycardia, increased blood pressure, and we'll see changes in their facial expressions. Okay. So their mouth will be square and open, and their eyebrows will be close together, drawn in. If you ever notice when Trump talks, like his mouth gets like a little square and his eyebrows go in, watch him. So for babies, that's what they're going to look like. The eyebrows come in, the mouth is open and square. Heart rate increase, blood pressure increase, change in facial expressions, eyes tightly closed. For children, okay, children can use drawings, happy, sad faces. They'll tend to withdraw, okay, or not communicate, especially those older kids and your teens. So for teens, withdrawal, lack of communication. Children, difficulty describing, and babies, the square mouth, the drawn in eyebrows, tachycardia, increased blood pressure. All right, referred pain. This is pain that happens a lot with people, let's say pancreatitis. So they'll be balled up in a fetal position. The pancreas is hurting, but they'll feel it in one of their shoulders. Gallbladder, I think it's the right shoulder. Someone that's having a heart attack, okay? Not the chest pain, but the pain in the arm and the jaw. That is referred pain. So it's characteristic of visceral damage in the abdominal organs or a heart attack or ischemia in the heart, but the pain is going to be distance from where the injury actually is occurring in the body. Phantom pain, we see this after amputations. Okay. A lot of times they might have itching or tingling. They don't really know why. These people don't usually respond to normal pain therapy. The pain can resolve in a few months, but the brain still thinks that the limb is there. That's what they believe. So they don't really understand why. Now, they may treat this with different things, depending on who the doctor is. Okay. But again, this is going to be more common if they had chronic pain originally before the amputation. All right. Tolerance is how much pain we can withstand. It can be increased by release of endorphins. So sometimes if you're in fight or flight, okay, these endorphins could be released and you may not feel the pain the way you normally would when you're in that fight or flight, okay? But if you're really stressed sometimes, pain feels worse. And it can vary among different people. Your perception of pain is subjective. So what we do is we try to compare it. Is it better today than it was yesterday? Yesterday it was a 4. What is it today? And the response to pain can be influenced by a lot of things. Okay. Some people have a little cut and they're ridiculous with the amount of pain that they're expressing. And other people could have their arm half chopped up and they're fine. Okay. So again, it comes back to personality, emotions, your cultural norms. Like for a long time, men would not show signs of pain because it was considered a weakness. Okay. That's totally changed, right? Totally. All right. Acute pain is going to be sudden, oncoming, usually localized. And as a response, we'll see physiological changes, some of the same ones that we see with stress. An increase in the blood pressure and heart rate, pale, cool skin, because the body is vasoconstricting there, okay? Increased respiratory rate, increased skeletal muscle tension. These people can vomit, and sometimes you'll hear them cursing or screaming because of those strong emotions. You have to know the difference between acute and chronic. All right. Long-term pain can lead to negative issues and depression. So it can cause people to lose their jobs, lose their spouse. It's usually harder to treat. And we usually can't identify or put a pinpoint on where the pain is coming from. All right. And the body can't sustain that stress response for a long period of time. So a lot of times this is going to lead to fatigue, irritability, and depression. These people can have problems with their appetite, and that can lead to either weight gain or weight loss. Again, it's going to affect their everyday life. Okay. So I'm sure everybody has somebody in their family that has chronic pain, and you can see the differences from who they were to what they now are. Know the difference, okay, between acute and chronic pain. Again, acute is going to be those afferent, acute, myelinated delta fibers, okay, A delta. chronic is going to be the slow C fibers, unmyelinated. How's it going to affect us? Okay. And we don't have to worry about treatment. Okay. Never worry about treatments or diagnosing for this class. All right. So we can have different types of headaches. The one they're going to ask you about the most is typically migraine and intracranial. But you can have sinus headaches, from pressure in the skull, from the sinuses, from inflammation and swelling, muscle spasms or tension. Okay. The TMJ, a lot of people have problems with their temporal mandibular joint. So that's like right below your eye. And a lot of times they'll feel it when they chew. And then migraines. Okay. These are related to abnormal changes in the blood flow and metabolism in the brain. These headaches are going to be throbbing, severe, and incapacitating. And then intracranial usually comes from some kind of increased pressure in the skull. This could be like a tumor that takes up the space there, or the meninges being inflamed or damaged. Central pain, this is caused by some sort of damage to the brain or the spinal cord, and it's not working properly. So they might have an abscess, a hemorrhage, a tumor. Neuropathic pain, this is usually caused by something like diabetes or fibromyalgia, where the pain is moving along the nerve line. So we can't treat it the same way. Okay. And it causes like tingling, burning, or shooting sort of pain. And here the nerves are becoming hyper excitable because when people move, it stimulates that pain. The nerves become hyper excitable, and that causes a lot of pain. It's a result of damage to the peripheral nerves. Okay. So we'll see this a lot with diabetics. The diabetes actually caused it, or it can be caused by infections. Your book doesn't list it, but neuropathy can also be caused by treatment of cancer. Okay. Because a lot of those chemo drugs cause neuropathies. Also, drugs for TB cause neuropathy. Ischemic pain, this is from loss of blood flow to the organ in a certain part of the body. So we have hypoxia there. The tissues are not getting nutrition or oxygen. So they're screaming here for help. So when you think about it like that. It's going to cause this aching or burning pain. Atherosclerosis can also cause blocking of the arteries. And that really is what leads to a lot of the ischemic pain. So here we're eating a lot of foods high in fat, that fried chicken, that fried fish, them collard greens, lard, any kind of grease that's not healthy for you. Okay. And that grease will, so if you take the grease, let's say you fried a bacon, all right, and then you let the frying pan sit there. All right. And then you come back a couple of hours later to do the dishes. What does the grease look like? It's thick, right? And it's stuck to the pan.
It's a solid.
Yes. Now imagine that same thing happens to that grease in your body. And it happens along the walls of your blood vessels. So now your blood vessels are designed to be at a certain diameter and the blood can flow through them. But as things start to accumulate on the sides, like those plaques, or when people have high blood sugars, because the blood sugar also damages those vessels. So now you have the plaque on the side and the vessels being partially damaged from the blood sugar if they're both. Okay. And if they have high blood pressure, that damages the vessels. So all these things are doing damage to the vessel. And so now we have either that plaque has accumulated to a point where the blood can't get through at all. Sometimes the plaque gets there and a blood clot will end up on it because the blood will now stick to these substances along the wall. And that's why people develop clots and things of that nature in there. Okay. Plus, the blood is already thick from other things, like they smoke or they have COPD. So all these things are contributing here. Okay. They're not getting blood flow. So the organs, the vessels there are screaming. The tissues are screaming because they need that oxygen in order to survive. The organs need that oxygen in order to survive. Cancer-related pain. This can be caused by the disease itself getting worse or from treatment, like, radiation, chemo. Again, if you look at your chemo drugs and what some of them do to the body, a lot of times that pain is going to be associated with that. But it also could be from the spread of the cancer itself, from pressure that a tumor is putting on a body. We don't care about managing, okay? We're not managing pain right now. So we don't care about it. Skip it. All right, let's see if I can stop this share for a second. We're going to pick up chapter 9 here. All right, so I think what I'm going to do from here is I'm going to open up my other PowerPoint. We'll recap a little bit on 4, and then I'm going to cover some basic points on chapter 9 because it's probably a really big chapter just based on the size of it. Let me see.
Good morning, Professor Loach. Are you gonna send that recording on YouTube?
Usually for tutoring, I do put it on YouTube.
Okay, thank you.
All right, let me see how many slides we got here. Whoo, 102. Okay, we only got about an hour, so we're not going to get through 102 slides in an hour. So let's pull up this other slide I got here, and let's talk about, we're going to recap a little bit on chapter 4. Let me know when you can see it.
Sir,
Okay, client cuts their finger on a knife while cooking. What type of pain?
is this B? Somatic.
Okay, why is
No.
it somatic over visceral?
It's the cutaneous is like under the skin.
Good. Okay, somatic comes from the skin, or cutaneous or deeper structures like the bone or the muscle, and it's conducted by those sensory nerves. What is a non-invasive treatment for someone that they could do to help manage their pain? We didn't talk about this, so we're going to skip this because that's not going to be on there. All right. the level of stimulation required to activate the nerve ending sufficiently for a person to perceive pain.
C, pain tolerance.
Pain
Perceive
threshold.
gate.
Pain.
Okay, threshold is the level of stimulation. Remember, I said these ones you got to know. All right, true or false? The threshold is relatively constant over time and among individuals.
False.
Okay, what's the difference between threshold and tolerance? Look it up in your book because you got to know this.
The threshold does not vary and the tolerance varies.
The tolerance varies because it's based on what?
The person itself.
Yeah, it's
Culture.
personal.
Okay. So the pain threshold is constant over time and among individuals. A person's ability to withstand pain or the perception of the intensity.
D.
Pain
Tolerance.
tolerance.
Okay, tolerance. Good. Pain tolerance does not vary from person to person, regardless of past experience and overall state of health.
False.
False.
False. It's the pain threshold that does not vary. Which of the following statements are true? And there's more than one.
A and C.
A and C.
Acute and chronic.
Okay, good. Each spinal nerve conducts impulses from a specific area of the skin called a blank. The blank can be used to test for areas of sensory loss or pain sensation and determine the site of damage after a spinal cord injury.
D.
D.
Dermatones.
G, German.
Okay, D, dermatones. What is A?
Isn't
That
that
sends
the like
Sensory,
Send
send
signals.
messages to the
the
brain.
efferent impulse.
Right, that's your sensory signal. That's going to the brain. The brain is going to sense something from this signal. Efferent is what?
From the
It's the
brain.
response.
From the
Reflex.
brain out. That's your exit signal. And that's usually going to cause some sort of a response to make you move from the pain or make something happen so you don't feel the pain, like maybe trigger those interneurons to release that endogenous morphine or those enkephalons. A synapse is just a signal that happens between two neurons for something to happen. One neuron is going to another, or neurotransmitter or something is going from one neuron to another. Which of the following statements is not true about migraines?
D.
D?
D. Okay, these can last up to 24 hours. All right, you want to know about migraines? Remember, I said that. This is all right in your book. It's probably also on your Cahoots. Endorphins resemble the drug morphine in the sense that they are secreted by blank in the central nervous system to block impulses to the brain.
Interneuron.
B.
Inner neurons. Good. Astrocytes, these are part of cells in the brain. Oligodendrocytes, also cells in the body. And neurons, motor neurons, are going to cause an action to happen somewhere. Enkephalin is released in the spinal cord and attaches to the opiate receptors on the afferent neuron, blocking the release of neurotransmitter substance P at the synapse. This process does what?
A.
A.
Blocks the pain or
Blocks
Prevents
the
prevents it.
pain. A client is admitted with meningitis and is suffering a headache from the increased pressure. What type of headache does the nurse suspect?
Intracranial.
Intracranial headache.
Intracranial. While teaching a student about pain, the nurse explains some differences between chronic and acute. Which of the following statements are true regarding chronic pain?
A.
A.
A,
A.
And C.
C, and I feel like D too.
A and C.
Yeah, D. A, C, and
Okay,
D.
why is D wrong? Remember serotonin? We talked
Oh,
about
it's
that
a
in chapter
reduction.
14, right?
It's a reduction of the.
Right. It would be a reduction, and reduced serotonin leads to depression. So watch your words. If the whole statement isn't true, don't pick it. Why is B wrong?
Because that's the paleo spinal.
The wrong track.
It's the wrong track. Acute pain travels on the neosporin track, right?
Mm-hmm.
Many organs, such as the liver, kidney, or brain, are characterized by pain receptors in the covering capsule, and pain is felt when?
B.
C.
B, when the capsule is stretched. A client is experiencing pain in the chest. The nurse suspects a heart attack. What type of pain is this client experiencing?
Ischemic.
Ischemic, because it's in the chest, okay? And that's the loss of the blood flow to the organ or the tissue. Client is experiencing right shoulder pain. The client is diagnosed with pancreatitis. What type of pain is the client experiencing?
Referred pain.
Okay, referred pain is when the sensation of the pain is identified in an area away from the source. A client with poorly managed diabetes is complaining of numbness, tingling bilaterally in the lower extremities and the feet. The nurse is aware that the likely cause of this condition is what?
D.
Neuropathic.
Neuropathic pain. Good. Cancer is associated with chronic pain. This pain is broken down into several categories. Which of the following statements is not included in those categories?
C.
C, because that's what?
Ischemic.
Ischemic pain. Good.
And sudden loss.
You don't need this one. This is treatment. A mother calls the doctor's office regarding her 2-month-old. The child is experiencing an ear infection. The mother is concerned the child is experiencing pain. What observations would the mom see?
I
D.
think it is
D.
D.
C.
D.
D.
D. Okay, and what's their face going to look like?
Donald
Donald
Trump.
Trump.
Okay, which
Donald
means
Trump.
what? Square mouth,
Square mouth.
drawn in eyebrows.
Eyebrows.
Yeah.
Okay. For blank that cannot be controlled with, no, you guys don't want to know this one. Okay. During a class, the instructor is explaining the function of nociceptors when we experience pain. Which statement is true?
D.
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 D. Okay, they're stimulated by thermal, chemical, or physical means. The nurse is documenting on a client receiving pain medication. Based on her observations, she understands the client is having acute pain. Which findings are consistent?
A.
A.
B. A and
B.
B. And D.
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 Okay, and D. Which statement is not true regarding the gate control theory?
Hmm.
Is it D?
No.
No, D is what I said happens when we do what?
B.
Hold on. Let's go back to D because we're guessing. D is what happens when we do D. What are we doing when D happens? What are we typically doing?
Ice and heat the ice.
Yes, ice, heat, or the TENS unit. Okay. Let's look at B. Gates in the pathway may close to reduce or modify the passage of pain impulses. We said that the brain can selectively decide, right?
Yeah.
So the brain can do that. We're looking for one that is not true.
C.
C. C is not true, okay? Interneurons will trigger the release of the endorphins or the enkephalins, right? And it'll do that either when the signal comes into the brain or it can do it when the signal is exiting the brain. Okay? Those are your interneurons, and they're releasing those endorphins or enkephalins, that endogenous morphine, right? To block the receptors, to block what?
The pain.
The pain.
From specifically, what are they blocking? What's being sent to the brain that's inducing that pain signal?
Is that like the C fibers?
Substance P.
Substance P. Substance P.
Remember, these block the receptors. The interneurons trigger. They block the receptors to block the substance P. So this has nothing to do with the gate. Either the afferent signal going into the brain or the efferent signal leaving the brain triggers your endogenous morphine and your enkephalins. When they trigger, they block those receptors to block the substance P. So that has nothing to do with the gate theory, okay? Everything else does. At the spinal cord, synapse, sudden pain results in a blank impulse back to the muscles that initiates a blank to move the body away from the pain.
B.
Okay, listen to the statement. At the spinal cord synapse, sudden pain results in a blank impulse back to the muscle that
Oh.
initiates
A.
a blank
A.
to move the body away from the pain. Efferent, because motor causes movement or action. So the efferent signal is sent back. It's an exit signal, but it's also a motor signal. And it's going to cause that reflex to happen. And the body will move away from the pain. Okay?
Mm-hmm.
Afferent is the incoming signal. So afferent is going into the brain saying, yo, we got pain here. What are we going to do about it? When a client experiences sudden acute pain after the sensory impulse reaches the synapse, connecting neurons will transmit the impulse across the spinal cord to the ascending tracts to the brain. Which track will the pain impulse travel along to reach the ascending tracts to the brain? So we're talking about acute pain here.
Spinal
Spinal
thalamic
thalamic.
Good.
tract.
Spinal thalamic tract. Okay. And we know that there are two types. The fast ones usually go on the neospinal thalamic, the slow ones on the paleo. The blank located in the pons and the medulla influences the brain's awareness of the incoming pain stimuli.
B.
Limbic system.
B.
Reticular activating system,
RAS.
the RAS. The RAS will
Arousal.
Arouse.
arouse your ass. Hey, ass, we have incoming pain stimuli. It's waking you up, okay? Some drugs depress that, like narcotics. So and I always say, when I take a narcotic, okay, it's not so much that I don't feel the pain anymore. My brain is like jello, so I'm not aware of it, right? Because
Yeah.
my RAS is what?
Depressed.
Yes, depressed or inhibited. So I'm not as aware. This is why if you're driving around on narcotics, the popo has a problem with it. Because you're not as
Alert or
Raz.
aware.
aware. Okay, it's scary. People on narcotics will do crazy things. Watch them when they're really high on narcotics. You'll bump into stuff, run into stuff. You're not paying attention. And so, it's taken away from your brain being aware of what's happening. This is chapter 9. So let's see what you know about chapter 9.
A.
Osteoblast.
Okay. Osteoblast makes the new bone. Osteoclast does what?
Destroys or breaks it down.
Destroys it or breaks it down. And what are osteocytes?
The new
New
cells.
cells.
Yeah, those are those bone cells, right? They're the most common bone cell. At the neuromuscular junction, the chemical transmitter blink is released to produce a muscle contraction.
D.
D. Acetylcholine.
Acetylcholine. Okay. Serotonin we see in things like depression when it's too low. Okay. If it's beefed up, then normally people are upbeat. If it's really beefed up, we could see like manic or mania. GABA, GABA dabba doo. Fred Flintstone's relaxed. How about you? When we have enough GABA, we typically don't have things like anxiety and seizures. Okay. Not enough could contribute to that. And then norepinephrine is an arousal drug. Okay. Your body naturally releases it, especially in fight or flight, to arouse you, to bring up your blood pressure and your heart rate in that sense of arousal. Okay. Not brain arousal here. We're talking about bringing up your heart rate and your blood pressure because your body is usually not responding to natural processes. So in the emergency room, we'll give this, we call it levo-fed or leave them dead. Okay. And that's another name for norepinephrine. This is a drug where we're going to try to increase your heart rate and your blood pressure because you're in shock and you're not responding. But your body naturally releases it in fight or flight. If you know what everything else is, then you know what not to pick, okay? A client is in the ER. The nurse suspects an open or compound fracture. First of all, what kind of fracture is an open or compound fracture? You will need to do that.
A.
A.
So because of what's going to be a high risk for these people?
Infection.
Infection. Yes. Okay. You should also know what these other ones are. They're in your book. Who knows?
Is B the one? It starts with a P. I can't remember it. I gotta go to the page, but it's like the pal. Hold on.
Manufacture. It's a fracture, right?
Okay, so if you go to slide 22 on your PowerPoint 9,
That's green stick.
okay,
C is good.
C is a green stick. Who does that usually happen to?
Children.
Children.
Okay, which one is impacted?
D.
D.
D. So we'll see this in motor vehicle accidents. Okay. Pathological is extreme weakness in the bone, and we might see that with things like osteoporosis or multiple myeloma. I think this is a comminuted fracture, the one with the crushed into many
Comminuted.
pieces, I gotta
Yeah,
call it.
The
yeah,
comminuted.
it's comminuted. It says in which there are multiple fracture lines and bone fragments. Oh no, wait.
No, wait a minute, because there's different ones.
Is that compression? Because
That might
compression
be
also
compression.
says
Yeah.
it says common in the vertebrae, occurring when a bone is crushed or collapses into small pieces.
Okay, so that is what you just said.
Okay, so compression.
Compression. Okay, so that can happen to older adults a lot. All right. So D, we usually see like motor vehicle accidents, like the pelvis, that the femur is crushed into the pelvis. C with green stick, which is common in kids because they have those soft bones. B is common in the older adult, compression, okay, with those vertebrae fractures. All right. And then A is high risk for infection, and that's when you have that open area. All right. Colley's fracture. So I remember this by one thing, and we'll talk about it, but let's see if you guys know what this one is.
Is that D?
D.
D?
Okay, D. So usually older people, when they fall forward. And what's the first thing they do? They put their hands out. Okay. So they'll break it right behind the hand at the wrist there. That's your Colley's fracture. Okay. C is child abuse. That's a spiral fracture. B is going to be pathological. Okay, because the pelvic fracture is related to the osteoporosis. So that's usually causing softening or breakdown of the bone. And A is POTS. So I think about when they stepped down, they stepped into a pothole. My friend actually got one of these kind of fractures one time. We were out taking pictures at a photo shoot, and she stepped into a pothole, and the force of her stepping down, it fractured her fibula. So I call it the pothole fracture. That just helps me remember we're stepping down with the force. You know, what will help you remember? But most of the ones that they test you on are going to be the compression. Okay. Probably the pathological and the compound. You also have to know this portion. Okay. So after the fracture heals, a hematoma is formed. That's the first step. How does the hematoma assist in the healing process?
C.
C. Very good. C. Okay. It acts as a network for the granulation tissue to grow. A client arrives to the ER following a car accident. The client was smashed between two cars, and the neck of his femur bone is crushed against the pelvis. What kind of fracture?
Compression.
Compression.
Infected.
Okay, it's crushed against the pelvis.
Isn't that impact? Yeah,
Impact. Okay, impact. Simple is just a single one. Green stick is that partial fracture. Remember, we said compression fracture is what?
Like when
Spinal
something
cord.
is like crushed, like the spine,
Yeah, and we're going to see it in older
multiple
adults, right? And it's
pieces.
going to be multiple bones there. A young girl's in the ER for menstrual cramps. What type of pain?
A.
Visceral.
Visceral. All right, nurses conducting a health screening for osteoporosis. Who's at the greatest risk? Whenever you see a statement like this, look for the one that has the most risk factors.
4.
3.
A, B, C. These 4.
Okay, so female, postmenopausal, she's both, and she smokes. 70-year-old man, first of all, he's male, right? The alcohol would give him a greater risk. Men can get it, but, it's not as common. So she has sedentary, meaning she's not moving. That's 1. 65 years old, age, that's 2. At 65, she should not have a period, right? That's
Mm-hmm.
3. And she smokes cigarettes, that's 4. You see it? You have to see that when you look at these types of questions, nurse. You got to see when there's more than one risk factor. Nurses caring for a client being treated for a fat embolus. So why do fat emboluses happen and where do they most often occur?
They occur with fracture.
What kind of fracture?
Hip fracture.
What kind?
Hip.
So usually it's going to be a long bone fracture, okay? It happens more in the long bones. It like your high school football players, when they fracture their femur bone. You'll see this a lot, okay? And the cause of it is what? Usually
Is that when it
improper
has,
go ahead.
it wasn't like stabilized correctly?
Yes, it was not immobilized correctly when they moved them. Okay? So this is going to move like any other emboli. So what are we going to see?
Respiratory distress.
Yes, respiratory distress. Okay? Again, more common in patients with the pelvis or long bone fracture like the femur, especially when it's not well immobilized during transport right after the injury. Nurses teaching a client in an arm cast about signs and symptoms of compartment syndrome. What are the causes?
D.
E.
Okay. Can A happen?
No.
Can A happen to a person?
Yes, it can
Yeah.
have spasms.
Yes, but it
Yes.
doesn't have anything to do with compartment syndrome, okay?
Yeah.
Okay. What about B? What is B?
Atrophy.
Okay, good. And this can happen. What is the procallus?
Mm, I'm not sure.
So once that hematoma develops, you're going to form like a little procallus, which is a little bridge in that bone, okay? The reason why we put a cast on it is because remember that bridge isn't strong enough yet for us to use that body part. And if we try to use it, it's going to damage it. So the cast keeps us from doing that. Once it's fully formed, then what does the doctor slowly do?
That's it.
Can you ask that again?
Yeah, once this callus is fully formed, what does the doctor slowly start to do? Because they look at this with x-rays, right? They do series of x-rays to see how well you're healing, right?
Mm-hmm.
So once this procallus is fully formed, what does the doctor typically start doing?
Like
They remove
remove the
like
cast and
remove the
start
cast and
Okay,
start
they may
healing
introducing.
the
remove the cast, or they may leave the cast on for a little while and they'll start with a little bit of what? Weight bearing
Like weight
and
bearing.
of
weight
that
bearing.
and use of that body part, right? To slowly see if it's healing enough that we can fully use it. Because we don't want to break this procallus. That would start the healing process all over again. All right, so the answer there was D. And I don't just want you to know the answer. I want you to understand what's happening. What is gout?
A buildup of the lactic acid,
Like
Uric
Lactic?
acid.
uric
Uric
acid,
acid.
uric acid.
Okay,
uric
uric
acid.
acid. Okay. What is it also, though? What kind of disease does this fall under? Why is it under bone?
Arthritis.
Okay,
Because
it's a
yeah, the
type of
joints and stuff.
arthritis. So your author might call it gouty arthritis. Yes, that's what it is, but we call it gout for short. Okay. What kind of things cause increased uric acid levels?
Your
So
diet.
Okay, so we'll see this in people that are diabetics, okay, that have poor blood sugar control. Also, if they eat certain foods like seafood, smoked or foods with high nitrates, um, other things that would increase uric acid levels, chemo, because it lyses the cells and sometimes it causes an increase in the uric acid levels. Okay, so again, what finding would you expect to note here? Okay. So what's our answer?
A,
Okay, why is it not B?
because it's not
It's
really
always
telling you
only on the
why
big toe.
how it's swollen. You could have stubbed your toe and that's why it's swollen or something.
I think it
It's
usually
normally the
is on
great toe.
one toe. It's
It's
only
the
on
great
one big
toe.
toe, the
Okay, it's
great
usually
toe.
on your big toe. That's why it's not B. And what happens as a result of this increased uric acid? Why do they have pain? Why do they have the arthritis? All right, inflammation
Increasing.
and the deposit of these tophi. Okay, these little crystals, these little tophi are deposited into the bone there, and that causes damage and pain. Oh, also, kidney issues. If they have kidney problems, okay, we'll have the
Hmm.
increase in uric acid. We missed that one. All right. The nurse is caring for a client with a long bone fracture at risk for fat embolism. The nurse specifically monitors for signs of this complication by performing an assessment of what items?
D and A.
Only D.
So it's only one answer
Oh, it's
here.
only one. By mobility doesn't mean how they can move or like mobility, like how secure the person's.
So what's the question asking you, nurse?
Oh,
They're
what were
at
the
risk
signs and
for a
symptoms?
fat embolism.
So it'd be respiratory.
Rest.
It's going to be neurologic and respiratory because this is going to cause confusion, okay, and respiratory symptoms. A client stubbed his toe and immediately felt pain. Impulses related to acute pain are transmitted from which of the following?
D.
D.
Myelinated A delta fibers.
Okay, so let me see what else I got on here because this is really not going to be related to pain. This is for something else. All right, let's go to how you guys feeling about chapter 9? Let's talk about some of the disorders for a minute, and then I'll see if we can get to some of the stuff for the eyes and the ears. All right, we went through fractures. I think you guys have a pretty good understanding of that part. Know what compartment syndrome is, know what your different fractures are. Also, you want to know the difference between dislocation, okay, and sublimation. Okay, so with dislocation, the bones are separated at the two joints and you lose contact between the actual surfaces. And usually there's going to be some sort of damage to the ligaments and the tendons. The problem with those is they take a really long time to heal because they don't get as much nutrients and oxygen as everything else. Okay, so whenever you have a ligament or a tendon injury, it's going to take usually a really long time for it to heal. All right, so the dislocation is the separation of the two bones at the joint. We lose contact between the articulating surfaces. One bone is usually out of position. Usually we'll have severe pain, swelling, and tenderness. Okay, and movement is going to be limited. And again, it can take a really long time for that to heal. All right, subluxation is when the joint is only partially displaced. So there's still some contact with the subluxation between the two surfaces. With dislocation, no contact. Subluxation, we have partial contact still in place. You should know the difference between sprain and strain. All right, sprain is a tear in a ligament. Strain is a tear in a tendon. So I remember strain has a T in it, T for tendon. So strain is tendon, sprain is ligament. Both of these support the bone, okay? Avulsion is when the ligament or tendon becomes completely separated from the bone.
Miss Sue,
Yes.
I had a question. I was doing the Cahoots last night, and one of the questions, it was like the answer was repetitive strain and sprain. So can you have both? I took a picture of it because I was it the question it said cause may be repeated forceful or precision movement, and then it said many of which are associated with work related activities.
So that sounds like carpal tunnel syndrome or a repetitive strain injury.
So it shouldn't be sprain, it should just be repetitive strain.
Yeah. I
Okay.
probably keyed it wrong, so I got to go in and look at it. If you could send me the picture on my email so I can go in and try to find it.
Okay.
All right, so if you look at slide 34 on your chapter 9, it tells you about repetitive strain injuries. These are things that happen over time. So this is like your carpal tunnel syndrome.
Okay.
Okay, and a lot of people will develop this if they work, like, let's say, even in an auto parts place where their job is to constantly do one thing. and that one thing causes movement of their joint repetitively. So when you're doing the keyboard, right, it's causing you to move your hand in a certain way. If you're a tennis player, you're swinging in a certain way. If you're a pitcher, you're throwing the ball in a certain way. Okay, so most of the time, this is going to affect that upper body. Usually, a sprain we'll see following some sort of injury. It could be sports related, or if you have really weak ankles, okay, you could just be walking and your ankle will sometimes roll out and you'll sprain it. They usually take longer to heal than even a fracture sometimes. Again, if you think about a sprain is the ligament and a strain is the tendon. So remember, ligaments and tendons take a long time to heal. About 6 weeks. All right. And then you have your repetitive strain injuries, which we just talked about. Okay. Repetitive movement, overuse injuries, which can sometimes cause muscle tears. So you'll hear people, they're going to the doctor because they have a rotator cuff tear or something along that line. And again, it's from overuse. So you might see things, athletes, a lot of times athletes will develop these, nurses can actually develop these too. If you're doing a lot of lifting and bending and you're using muscles and stuff that you're not used to, or that are just tired because you're doing it all the time. All right, that's treatment and all that, so we don't need to know that. I really haven't seen them ask about the degree, but third
We're
degree
not
is going to
seeing
be
the slide, Miss Loesch. We're seeing a different slide.
okay.
Thank you.
Can you see it now?
Yes, thank
Yes.
you. Yes.
Okay, I haven't seen them ask too much about the muscle tears, but first degree is going to be a small percentage. Second degree is a little bit more. Third degree is a complete tear. So just know the differences there. Okay, osteoporosis, they like to ask about. So it's a decrease in the mass and the density. And we either have a primary or secondary form. So secondary is usually caused by something else. Primary, idiopathic, meaning the idiots don't know why we have it. Usually happens to people over 50. Now we have a decrease in what the body is producing. So the body's not producing the same amount of sex hormones. We have a decrease in our intake in certain foods, especially those that contain calcium. All right. And usually these people aren't moving around a lot. So osteoporosis itself is a metabolic bone disorder. We have a decrease in the bone mass and the density. And we're also losing bone matrix, which is that hardness, okay, and mineralization, which is that hardness of the bone. Women have a higher risk. Men can get it. Usually, primary causes are from post menopause. Okay, again, we're not producing the same hormones. We don't have enough calcium. Secondary, usually from something like Cushing's syndrome, where we have too much cortisone in the body. Okay, so it's damaging the body. So in osteoporosis, what is the cause? Because that's what you're going to have to know for the test. Okay, so your bone reabsorption exceeds the ability of what your bone is making. So your bone is pulling up the old bone, but it's not making enough new bone. And you lose that compact bone, which is that hard bone. All right, so this can lead to compression fractures. Remember those small pieces of bone, right, in the vertebrae. This is your older adult. It can also lead to kyphosis, which is where they have that hump on their back. And that kyphosis can lead to problems with breathing because now it's pressing on the lungs. And scoliosis, which is that S shape. Okay. Again, I would know the factors. So, too many steroids, Too much of that parathyroid hormone, not enough estrogen or testosterone. Those are your sex hormones, right? Sex things that we need that control our body. Calcium, vitamin D or protein, not enough. Smoking cigarettes. Now, remember that question we just did? She had the sedentary lifestyle. She was 65. She smoked cigarettes. Too much caffeine. And usually we'll see this in Asian or very light bone structured women, but also white women, small statute, sedentary lifestyle is big here. Okay, because you have to be walking on those bones and working them for things to work right, like the reabsorption or the production. Okay, so here the reabsorption exceeds the production. Rickets, osteomalacia, that comes from a lack of vitamin D. Okay, so either we're not getting enough sun. This causes weak bones. So in your kids, you might see like bow-legged. In your older men, what do they become? Bow-legged with that little shuffle. The bones become soft, so they bend. And they can have compression fractures, which are what? Look it up again. What are those compression fractures? These are the types of questions I would expect to see.
Well, like the
Paget's.
result.
Paget's disease, okay? Here we're going to have pathological fractures because the bone is being destroyed and it's being replaced by fibrous tissue. Again, in the vertebrae, compression fractures, kyphosis. These patients can also have increased pressure in the skull, severe pain, pathological fractures. Osteomyelitis, this is going to be infection of the bone. So my niece got this. She flipped her ATV. She had to have her arm reconstructed, a lot of bone grafts and other grafts. So as a result, she hit it, just bumped it on the wall about 3 years after the grafts and everything were done. Okay, it was enough to cause infection. And she ended up with osteomyelitis. It's very painful. It's usually caused by a bacteria or fungi. And how will they present? We don't care about treatment. They're going to have inflammation and bone swelling, fever, chills, malaise. They might ask you about this. I would expect them to. You should know the difference between these three types of curvature of the spine. So lordosis is a sway back where it curves inward at the lower back. Okay, so that's going to make the stomach kind of protrude. Kyphosis is hunchback. So they're going to have, you see this on a lot of your older ladies, where they're bent over and they have this hunch on their back. Remember, that affects respiratory. Scoliosis, we monitor our kids for this. This is usually an S or a C shape. Okay, but it can happen as we grow older as well if we have certain bone conditions or lack of certain things in the body. You guys have those slides, so I'm not going to go into them. Look them up. You should know the difference, okay? Tumors, okay? So osteosarcoma, this is a tumor in the bone, and it happens mostly in the long bones on the leg. We'll see it in kids, adolescents, and the warning sign here is bone pain at rest. So when they're resting, they're hurting. Ewing sarcoma is another one. Okay, that is a malignant tumor in adolescence, and that also occurs in those long bones in the diaphysis. And then your chondrosarcomas, these come from the cartilage. They're more common in older adults. But the Ewing sarcoma, they like to ask about, okay, and also the osteosarcoma. So those two I would really know. Now, bone tumors can metastasize to the lungs, So that can lead to other problems, okay? Muscular dystrophy. You want to know this, Duchenne's. They're going to ask you about this. This is mostly going to affect boys. Why? Because it's autosomal recessive and it falls on the X-link, okay? X-link inheritance is for most cases here. Remember, boys have 2X chromosomes. So usually if mom is a carrier, she will give it to the boy. What are they going to ask you about? Gower's maneuver. Okay. So their legs become hypertrophic, their calves especially. Okay. This is a metabolic defect, a deficit of what we call dystrophin. So I would know that. That's the cause. The deficit of that dystrophin, which is a membrane or a protein for the muscles. Okay. Because they don't have that, it causes degeneration and necrosis of the cell. The skeletal muscles become replaced with fat, fibrous connective tissue, and that causes the calf to look big like that. They lose the muscle function over time. These kids are going to die fairly young, around 11 or 12 years old, probably. Okay. They'll develop cardiomyopathy because it affects the muscles, and the heart is a
Muscle.
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 Okay. We'll see signs of this around 3 years old. They'll develop motor weakness and regression. Classic signs: weakness in the pelvic girdle, causing a waddling gait, when they try to go up the steps or when they try to stand up. So they'll climb up their legs to try to stand up. They'll use their legs. That's what that Gower maneuver is, when they're pushing themselves up by using their hands to climb up the legs. Eventually, that weakness will spread to other muscles. Okay, they'll develop contractures, kyphoscoliosis, respiratory insufficiency and infections, cardiac abnormalities. So, it's not a great disease for them. Again, they look for genetic abnormalities. Okay, they lack that dystrophin. Mom usually carries it. Son usually ends up with it, the defective dystrophin. They list a bunch in your book. Okay, Duchenne's is the one they put the most attention on. Fibromyalgia. Okay, this is characterized by pain and stiffness in the muscles that are affected, the tendons and the soft tissue. It does not affect the joints. These clients do not have any obvious inflammation or degeneration. They don't know what the cause is. They do believe there's a problem with neurotransmission. Okay, and that causes the soft tissue sensitivity to substance P, and that might be leading to some of the pain. We usually see this in women between 20 and 50. So what do they look like? Aching pain that's generalized. They can't really put a specific spot to it. Fatigue, sleep disturbances, depression. Myositis, this is severe inflammation and damage of the muscles. So we have poliomyositis, dermatomyositis, and juvenile. These clients are going to have difficulty with climbing stairs or lifting their arms. They'll feel tired after they stand or walk. They'll have trouble swallowing or breathing. Why? Because muscles, respiratory muscles. Muscle pain and painness and sore. Muscle pain and soreness. They'll test for, probably if someone starts to develop this, first they'll test ANA. and they'll look for some sort of maybe lupus or some sort of autoimmune issue. And then when they don't find that, then they'll start to look a little bit deeper at the muscles. All right, for the joints, osteoarthritis. Okay, big thing here, wear and tear disease. All day is what they're going to refer to this as. Osteoarthritis is wear and tear. Osteoporosis is when we're not producing enough bone and we're reabsorbing more than we're producing, and it's breaking down the density and the hardness of the bone. Okay, you have to know the difference. They're going to ask you about it. Osteoarthritis is that wear and tear. That's what I have, old people's disease. Okay? Too much weight on the body can contribute to this. So we get a little bit overweight. Now we're putting more wear and tear on the joints. Eventually, the cartilage wears down and it's bone to bone. So that's why they call it wear and tear. It's a major cause of disability and people being absent from work because normal people would call out, but not nurses. It can be caused somewhat by genetics. Okay, genetics might be wearing the joints down quicker. Again, you have to know that there's erosion, okay, mechanical stress, and it's just breaking down the body. Again, bone on bone. Think about that. What's it breaking down? There's no synovial fluid there, okay? You don't have that cushion from that synovial area because it's damaged. The joint space becomes narrow. It can cause inflammation. These people are not going to have systematic effects either. It's really going to be just within that joint or that area where it's damaged. Okay, so they'll develop things like bone spurs, inflammation, loss of motion or range of joint motion. And it's very painful when you try to walk or bear weight. The primary form of osteoarthritis, again, is going to be caused by weight bearing, obesity, aging, but also trauma. Okay. So, like for my knees, I was worked in a mental health place and I had to do takedowns or got taken down in the process of a takedown. So I tore my meniscus 2 or 3 times, sprained the ankle a couple of times, twisted it, broke it. So over time, all those factors play a role on those joints. Again, weight bearing joints most often, but it can involve the fingers as well. So signs and symptoms are going to be that pain with weight bearing. Again, osteoarthritis, wear and tear. It limits your social activities. Walking is difficult. It puts people at risk for falls because they compromise the way they walk. Rheumatoid arthritis. This is autoimmune. Okay. And it causes inflammation throughout the body. It happens more often in women. It can affect any age group. All right. Young women get this. And it's a major cause of disability. But as we grow older, the risk factors get worse. These people will have remissions and exacerbations and progressive damage to the joints. It usually starts with these small joints symmetrically. So, like the fingers, then the wrists, the elbows, the knees. Usually, they'll have an abnormal immune response that causes inflammation of the synovial area. And that causes eventually the joint to become red, painful, and swollen. Synovitis is inflammation of the synovial membrane. And then they can develop something called pannus, which causes additional enzymes and inflammatory mediators to be released. That causes damage to the cartilage there. The cartilage starts to break down, and before you know it, you don't have any cartilage, you don't have any synovial fluid. The cartilage is eroded, and that causes the joint to become unstable, making you at risk for falling and other damage. These clients can develop something called ankylosis, where the joints become fixed if we don't treat it. Okay, so muscles can become atrophied, the bone alignment can shift, muscle spasms, contractures, deformity. Again, it starts with the immune system attacking the joints or the synovium. It affects the hands, the knees, the ankles, usually on both sides of the same joint on both sides. It also can affect the eyes, the heart, circulation. It can also cause blood vessel damage, okay, and iron deficiency anemia. Again, you'll see things like this. They might put a picture of this on there. Remember, ankylosis is fixation of the joint. Again, exact cause not known. Genetics, family predisposition goes back to genetics. Small joints on both sides of the body usually affected. All right. Other things that they're going to have is fatigue, depression, anorexia, iron deficiency, anemia. Juvenile rheumatoid arthritis. There's a few different types. This is going to be a more acute onset, so it happens quicker, and it will more likely affect the large joints than the small ones. They might not have the rheumatoid factor present either for these kids. And again, the large joints over the smaller joints. And Still's disease. This is a second type of juvenile rheumatoid arthritis. And a third type is the one that affects either fewer or less joints, but it causes problems with the eyes. So I would expect them maybe to ask you about the juvenile rheumatoid. They probably won't get very specific about the other two types, but I definitely would know rheumatoid arthritis itself, know the difference between that, osteoarthritis, and osteoporosis. Also, this next one you got to know. Infectious arthritis, also known as septic arthritis. This usually happens in a single finger. So, like a person that works in a dental office sticks their finger in somebody's mouth and it either punctures the glove or they didn't have a glove on and they get an infection there. Okay. And the joint becomes red, swollen, painful. Bacteria gets into it. There's a picture of it in your book. Psoriatic arthritis. This is also autoimmune. It comes from psoriasis. They don't really know the cause, but it's genetic and environmental. These people are going to have tenderness and swelling of the small joints on one or both sides. So remember, with rheumatoid, it affects both sides. This could affect either or. Swollen fingers, toes, morning stiffness, scaly skin, because they also have the psoriasis. So they're going to have a combination of both symptoms there. All right, this can also affect the nails and the eyes. Gout, we talked about a little bit, so I would know it. Okay. Remember, also known as gouty arthritis. So they get those deposits called tophi, okay, of those uric acid crystals in the joint. And that causes the inflammation and the attack. The tophi is just those uric acid crystals that are being deposited there. Okay. So you got to know about that. I would know about it. Again, we have too much uric acid in the body. It can happen when it breaks down purines that are found in the body or that come from the foods that you eat. Also, it can be caused by damage to the kidneys. The kidneys aren't releasing the uric acid. Ankylosing spondylitis. This is a chronic progressive inflammatory condition. It affects your sacroiliac joints, your intervertebral spaces, your costovertebral joints. It can cause peripheral joint involvement, usually worse in women than men. Happens between the ages of 20 and 30 for most people. It's considered autoimmune with a genetic basis. So first, the vertebral joints become inflamed. Then, because of fibrosis and calcification, the joints become fused together or fixed together. This causes the person to lose mobility. We'll see inflammation in the lower back around those sacroiliac joints. It can move up the spine and lead to something called a poker back. These clients will develop kyphosis because of postural changes associated with the rigidity and the loss of the normal spine, that curvature. It's losing that, okay? And so osteoporosis can also contribute to kyphosis. It can also contribute to kyphosis because of the compression fractures in that vertebrae. So those compression fractures themselves can lead to the kyphosis. Also, that is going to affect lung expansion, okay? And we also may see calcification of the costovertebral joints that restricts our rib movement. So that's going to also affect the way we're able to breathe. All right, so these clients will usually have low back pain, morning stiffness. As the calcification continues, the spine becomes rigid. We'll see more flexion, extension, and rotation being impaired here. So they have very limited movement. Some of the people will have systemic signs like fatigue, fever, weight loss, and it can affect the eyes, especially the uvea, and lead to uveitis. That's like in the middle part of your eye. Again, we have ossification of the disc, the joints, the ligaments. All right, and bursitis. This is when the bursae, these are little sacs that you have in your body, and they can become inflamed. They have fluid in them, so they kind of help cushion and protect certain areas. All right, but they can develop fluid in them, and they can develop inflammation in them. And so sometimes you might notice them on your hips, like if you're laying on the concrete floor in the basement watching TV with the kids, on your hips, and you notice that you'll get a little bit of soreness there at your hip where you were laying. A lot of times that's because the bursae there that are supposed to protect those hips becomes inflamed. You also have it like on your elbow. So somebody that plays a lot of tennis or may have injured their elbow in some way may feel some swelling and some pain there because that bursae become inflamed. And then synovitis, this is where the synovial membrane itself becomes inflamed. The joint movement becomes restricted. It can cause redness, swelling of the joint. And again, they can look at the synovial fluid for infection. Sometimes they'll just take out some of the synovial fluid because it'll build up in the joint and it'll restrict that movement. And then sometimes they have to give things like steroids and stuff to try to reduce it. All right, so that's pretty muchly it for today. Questions on anything I went over?
No, thanks, Miss Sue.
All right, have a good day.
Thank you.
Make sure you
Thank you.
watch chapter 15 on my videos.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Flourish.
Take care. Miss Howard, are you on here?